This is exciting for me, this lecture particularly, because there is nothing, as much as you guys think that I enjoy talking about acne or hyperbilirubinemia, there is nothing more that a pediatrician likes to talk about than poop. Nothing. Nothing that we love to talk about as much as poop. So this whole lecture is basically talking about poop, which is great. So, be excited, and I'm excited now that I get to do it for 2 or 3 days. GI is a big section of your pants, so it is on there for you. So when we talk about things that are specifically for peds GI, there's going to be 2 different things. So we're going to talk about the common things that have a physiologic manifestation, their anatomy and or their physiology are having something is going amiss, and they have pathology that we can see. Then there's the second category where it's more of the functionality. Their anatomy looks just fine. Their physiology seems to be doing fine too, except they're truly having some sort of symptom. So they are having a somatic manifestation of something that is going on. So it is still very real, but it's on the functional side. So when you get into the functional realm of these things, that is really when you start having your specialists, and some of you would truly be sending them to see me or a peds GI, as opposed to managing that as a primary care PA. So for studying purposes, I need you to focus more on the common ones that have an anatomical and physiologic kind of common things being common there, and have the red flag symptoms of your functional ones and some of the basic things, but really spend your time with what the common GI disorders are. When we talk about gastroesophageal reflux disease, and what you have classically been learned or taught is you'll hear reflux. Right? You'll just talk, they have reflux. Well, the problem with that, in my world especially, is that words matter. And so there's a difference between having gastroesophageal reflux and gastroesophageal reflux disease or disorder. Okay? So if you think about a baby, babies are pretty floppy. So they come out and they're just floppy. We've talked about this sometimes. Their heads are floppy, their limbs are floppy, they're just kind of flopping around, laying there like a cockroach. Well, the other things that are floppy in these children are their lower esophageal sphincter. And so if you think about that in an adult, when you eat food, it goes down, the door opens, and then it shuts. It is like a trap door, right? Not so for a baby. A baby, they eat their all liquid diet, and it goes down, and they have a functioning saloon door. So every single baby is going to have a physiologic gastroesophageal reflux for that very reason. It's floppy, it's meant to, and they have an all liquid diet. So it's kind of that perfect setup again to have this. So if you hear families that say, my baby had reflux, in your head you can think, well, every baby has reflux, because that's physiologic. So that is what you typically hear of when you hear the baby's spitting up. Super normal, should happen in 100% of babies at some point. And it's really normal to be happening all the way up through a year, because that's really when they are on considered an all liquid diet, where they are having mostly formula or breast milk. Right? At 6 months, they're starting to supplement, but still mostly a liquid diet. Things that we are going to make it worse or better, right? What's going to make it worse? Well, the baby's laying down like a cockroach all the time, so gravity's not on their side. So that horizontal positioning can make it a little bit worse. The liquid diet, and then that immature sphincter. So when is that normal? A distribution pattern all the way up to 2 years is still considered. It could be physiologically normal. Typically the mean about 12 months. For most babies, once gravity is on their side and they start eating solid foods, you see significant improvement. Most of your babies, 4 to 6 months, we're good to go. Right in the middle of the year, up to 2 years to be normal. When we have the disease, now gastroesophageal reflux disease, something is not normal. So they're still going to have that saloon door kind of response. They still have the liquid diet. But now you have a couple of things. Now they either are not able to keep enough nutrition down to be able to grow. That would be one thing. So if you are seeing such severe reflux that they aren't growing and they are in that diagnosis of failure to thrive. So I'll give you an example where I can give you the indications of failure to thrive and expect that you're going to be able to pull out reflux from that. If they're having significant pain, so have you ever been around a baby who eats all of their breast milk or formula and then happily just spits it all back up to you, right? And then just kind of looks at you and giggles and you're like, that was rude, right? That's very different than a child who post-feeding is very uncomfortable, kind of writhing around, crying. You can tell that there's pain associated with that. So if they're a happy spitter, totally fine. In pain, not normal. And then if there's any kind of respiratory difficulty with it. So those are going to be those three things that really take you from I'm normal, supposed to have this, to I'm not normal, and I am outside of that curve. Those are the babies then that you need to treat, because those are the babies that are having significant complications from this. We used to do these gigantic workups for these kids, where we used to put in the pH probe. We would admit them and put pH probes in. We would do upper GIs to confirm what we already knew was going on. We did upper endoscopies. So we did a lot of that. Really, none of those were great. We gave a lot of kids infections from hospitalizing them. We did a lot of unnecessary procedures. And so really at this point, you can do this. It's still the pH probe is your gold standard if you really were looking at that. If you really thought that there was something else going on, like an esophagitis, eosinophilic esophagitis, be something like that, you would do the EGD. But most of the time at this point, we're making a clinical diagnosis. So, if you're making those lifestyle modifications first for either GER or GERD, one of the things you're going to be doing is making sure that gravity is one thing you are using. So all the way as young as they get, you can still feed a baby sitting up. So that might mean that you are holding their head and neck a lot more than your older kids. But if you think about, picture yourself laying flat on your back trying to drink a half gallon of milk. And you tell me how comfortable that sounds, right? It sounds really difficult. So sitting the baby up and harnessing gravity is going to be very, very helpful. You can try a hypoallergenic diet. What does that mean? We talked about that in block 1. Some of your partially hydrolyzed formulas that are already broken down, or having mom cut out some of the dairy in her diet can be helpful just for the breakdown so it moves a little bit quicker. Because if it's not there, it can't reflux back up. Smaller or more frequent feedings. When you tell a mom this who's feeding every 90 minutes, she might cry, but it's something to at least talk about as an option. And then really, we got away from this. We used to do thickeners. So we would thicken up the formulas. We put rice cereal or these different gelatin kind of thickeners into their breast milk or formula. And we realized we just fattened up the babies and their sphincter is still floppy. So we didn't fix anything, we just made some bad babies. So really, we've gotten away from these thickeners. And if we need to thicken consistency, it's really because they're having those respiratory issues now, and speech therapy is recommending that. If they're in older kids, now we're not talking necessarily the babies, but you have a 5, 6, 7-year-old child who's got some GERD going on. Certainly if there's an obesity component, we need to manage that weight. At what age would we want to have weight loss versus weight stability? 7, yeah, perfect. Good recall from block 1. We want to elevate the head of the bed and to harness gravity in the older kids. Try to avoid that a little bit as much as you can in the younger ones. Daycares really hate the elevated head of the beds, a fight that you might end up having. And then acid-containing foods. Anything, caffeinated drinks is going to be difficult. Lemon, tomato. So a lot of times you see kids that are like, I love pizza sauce, and they're like, take the cheese off, and they just eat a ton of pizza sauce, and then you're like, yeah, that probably hurts. And you can see it, you need to go to bed. So again, please know the difference between GER and GERD. Be able to pull out which baby needs lifestyle modifications and education only, or who's going to be needing medical treatment. So when you think about the treatments, I need you to pair that up with physiology though. Okay, so if we're doing a proton pump inhibitor, which is going to be your first line for these babies, so an omeprazole or any of the prazoles is what liquid version is what you can use. Yeah, that is going to be your first line. I thought I changed that. That is not going to make the sphincter more tight. It's really just going to change that pH and help with the symptoms. Okay? So really think about, what am I treating? So a lot of times parents will come back in and say they're still spitting up. Like, well, yeah, all I did was change the pH. I haven't made the sphincter more tight. So make sure you're giving that education. The second line are your H2 blockers, and I thought I changed that. Ranitidine was taken off the market, so now it is famotidine. So you've heard Zantac is no more for the babies, now it's Pepcid or famotidine. And then metoclopramide, we're really not using that as much anymore, but if you had tried several, you didn't get down there, metoclopramide can be also used. Surgical indication would be if they are truly in that category where they're having respiratory issues, they truly cannot be made where they're having such severe pain with maximized conservative treatment. That would be an indication for surgical referral for a consideration of a Nissen. And that would be the only thing that anatomically is going to change how the sphincter and how that closure is going to operate. A quick word then on functional disorders, and again, we're really not going to spend much time here, so please don't focus a lot of your study time on here. But this is going to affect up to 1 out of 10 children. And if you think about this, this makes a whole lot of sense. How many times have you PCS'd, or you deployed, or you started a new job, or started IPAP, or thought to yourself, I'm moving to phase 2 and I don't even have orders, and oh my god, I'm not going to remember anything, and have a little tummy ache from that, right? That's an example of functional abdominal pain. Now superimpose that onto a child. Makes sense how they have this somatic manifestation of everything else that is going on in their life. So this is the absence of any structural, biochemical, or physiologic thing that we can find in these kids. And really, it's in that school age. So as they're first entering the world by themselves, I'm going to first grade, it's the first time really on my own, and up through middle school, so I do not understand how this does not include high school ages too. But it's not going to be associated necessarily with meals or with defecation, often associated more with the underlying anxiety component. This is not a diagnosis of anxiety for these children, but just kind of an idea of what's going on below the surface, right? Are you getting bullied at school? Mom and dad getting divorced? Are you have a pending move? You're hearing things going on. Usually worse in the morning, and this makes sense with the gastrocolic reflex, and also before going to school. So a little bit of some physiology there, but really thinking about starting the day with that. So children, yes, can have irritable bowel, can have some functional abdominal pain, meaning you really have no idea what's going on. It just hurts intermittently. Cyclic vomiting syndrome is super interesting. For no reason, these kids will vomit for several days in a row or several times in a day. Nothing is wrong that we can ever find, and it is kind of this predictable pattern. Some association with atypical migraines are thought to be with that, and yet that's a distinct difference from the abdominal migraine. So again, this would not be the place to spend your time studying, but an area that has a lot of research if you are interested in that type of stuff. The thing that this slide points out is really to look at the age at the bottom. So if you're looking at this, the bottom is going 0 to 12 months, and then suddenly we jump up to years. So you see a lot of things that are happening in that infant stage. We talked about colic being one of them. We talked about some of the GER, some of that infant rumination syndrome that you might have, some constipation throughout. And then you see these older kids with the functional stuff. So really the takeaway here is that the toddler years are the golden years, right? From 1 to 3, you're just living the life, right? So if you have pathology as a toddler, and it's outside of kind of that functional diarrhea or constipation, that would be something that I would take a little bit more into consideration, because typically they don't have the functional issues, right? It's more the younger and then the school age kids. As a reminder, visceral versus somatic pain, a lot of the times we're talking about visceral pain when we're dealing with the GI system, because we're dealing with those GI organs. So it's when you ask a kid, where does it hurt? And they just kind of like, here. And then you say, point with one finger where it hurts, and they take their one finger and then they say, here. And like, that wasn't particularly helpful. But they're describing to you visceral pain. They just don't have words for that. Versus somatic pain, it hurts in my right lower quadrant, and I have anorexia associated with this, and fever and leukocytosis. I'm not going to tell you that. These are going to be your red flags then. So this would be the thing to know for the functional syndrome in general. And this makes sense because any of these things, you have some sort of true pathology or physical response. So a fever, obviously, elevated bilirubin, blood in your stools, true dysphagia, where it's pain with that. Anything that you see that has these red flag symptoms are really going to take you outside the realm of functional. So really when you're thinking functional, it's this recurrent pattern of I don't really have a great pattern, you can't find anything, but it's very real and very distressing to the child and the family. So it's really what I want you to do as your takeaway from that. Some of your examples. So we talked about some of the Rome 3 criteria here when we talked about polycythemia. But some of the things that you need for diagnostic criteria, and again, this is going to be more in that GI realm, but is it episodic or continuous? You don't have any of that evidence of some true underlying inflammatory or anatomical issue. And then there's that impairment of function. So any of your functional disorders for any system, kid or adult, what is the functional impairment? And you will need to be able to specifically talk about that. And then what other somatic issues are they having? Does it accompany headaches? Does it accompany sleep issues? Does it accompany any kind of other pain associated with it? So you see that often in some of your diagnostic criteria. What would your workup be for these kids? So these kids would be ones that, yes, you're always going to do a complete history and physical examination. You would be getting a CBC to make sure the cell lines are okay, to make sure that you're ruling out any type of anemia. Your inflammatory markers, so you can throw a CRP on there as well. Again, never going to be diagnostic, but it can show you are they in a pro-inflammatory state or not. Amylase lipase is going to check out that pancreas and make sure salivary glands are okay, so anything in that GI region. UAs can mimic all kinds of stuff, so are they unable to process organic acids or proteins, or are they spilling proteins, spilling glucose? That could be one of the things. The most interesting presentation of type 1 diabetes was just a kid that had non-specific abdominal pain. So had I gotten a UA, I could have diagnosed it that day, because they would have been spilling glucose in their urine. So UA on that can tell you a whole bunch of stuff. And plus or minus for at the PCM level, if you're doing the workup, you have an abdominal ultrasound that at least tells you I got all the organs and they all are the appropriate size and shape and doing grossly what they are supposed to be doing to be helpful to the specialist. And then did I try a lactose-free diet? So that would be one of the things. Why would we not want to do a gluten-free diet for this? You want to try a couple of lactose-free days to that improve. But how do you make the diagnosis of celiac? You guys have GI? Yeah. So why don't you want to try a gluten-free diet? Yeah, you have to be eating gluten to be able to have those antibodies that are positive. Right? So that is something that the GI specialists are going to need to know, and you're going to be able to get. So that's later on in the lecture. What I don't want you guys to be ordering is CT scans. This is not an indication for just like, let's just throw it up for a CT scan. So abdominal ultrasound, absolutely. CT scans, no. And then again, what is their functional impairment? Are we missing multiple days of school? Are we unable to do any kind of sports activities? Is it when it's at mom's house, not dad's house? All kinds of that functional impairment. Let me just finish this one. Yep. Diagnostic challenges, again, nothing that we can find specific. Look for those stressors. Make sure you do that basic workup before they go. I apologize for 2 minutes over, but that will help you on the best. So, questions, Karen?